exciting thing about glaucoma is we keep learning more and more about treatments that we can employ to buy more time. And why do we want to buy more time? It's because we have an aging population and amazing developments in medicine where people are living longer. So it's important for us to think about that the patient in front of us is, going to live for a long time, and we need to keep them seeing for a long time. So every patient that comes to me, I make a plan looking into the future and assume that they're going to live to 100. And here's where all the new science helps us. So the first, I would say, revolutionary idea in glaucoma came in 2019 with the LIGHT trial. The LIGHT trial it studied a treatment we already had and we already used, and we already suspected for many years that it was very, very good as an early treatment, called SLT, or selective laser trabeculoplasty. And what that laser does is it's a cold laser, so it doesn't actually cause any holes. It just warms up parts of the drainage system. And what we know about it is that we think it changes the collagen or other support tissues to allow more drainage. It's got an 80% success rate when used as a first treatment. And at the 6-year mark, so in 2023, the follow-up study was published that showed at 6 years, if you had laser first versus a drop first, you were half as likely to need surgery for your glaucoma at that time frame. Patients' quality of life scores were better, and they had less visual field progression. So in many ways, the laser can buy us a few years. Now, laser is not a permanent treatment because, as we discussed before, glaucoma is a progressive condition. And actually, going back to your question of what are some of the biggest misconceptions about glaucoma, one of the misconceptions is that, oh, well, I'm on drops and the pressure's always 15 and that'll be fine, kind of thing. But it's not like that, because it does change over time, and that change might be slow or it might be fast. So depending on how much drainage capacity you have, we may need to escalate therapy. So laser is a good one to buy us a few years off drops. It's a very innocuous treatment, very few side effects, and it can be repeated if it wears off. Next is the advent of preservative-free drops. So in recent years, we've come to know scientifically that drops with preservatives in them, and particularly certain types of preservatives, they both affect the ocular surface, reduce the quality of the tear films. Some of them have an effect of actually reducing the amount of tears produced by your eyes, and they sometimes just affect the patient's quality of vision and quality of life, which are things that are previously we weren't so aware of until we started looking at patient-related measures, which is a new thing in the world of science and medical science. And so preservative-free drops are an excellent tool to employ to help patients use their drops and not get red eyes and not get itching and discomfort the whole time. And then, of course, minimally invasive procedures. So there's been an absolute exponential rise in the number of things we can use to help the drainage system, both in the early and moderate phases. So the way I explain it to patients is, depending on how much your trabecular meshwork is draining, we may need to help it a little bit, and we help a little bit with laser, help it a little bit with minimally invasive procedures. And often they come up when we're sort of at the end of the line and the number of drops the patient can tolerate, or we're not getting the pressure lowering that we want, which is called the target pressure. So we set a target pressure for each patient at the outset, and we may need to revise that through their course of glaucoma. Or if they're coming up for cataract surgery. So let's say they have a symptomatic cataract, which is the lens in the eye going milky and affecting vision. That's an opportunity, because we're already making a microscopic 2mm incision, and we can use that same incision to put in small devices to help the drainage meshwork and reduce the dependence on drops or give us more control. And again, the science behind these devices is many of them work for 5 to even 7 years. Some of them have been around for a long time, some of them are new, and sort of different types of patients may be more suitable for them. But certainly cataract surgery is an opportunity that should not be missed to enhance the function of the drainage system. The types of MIGS, or minimally invasive procedures we have, there's the ones with implants left behind, and the ones where we do something to the drainage system but there's no implant. So the first one is the implants, and we can put in 3 microscopic stents, and they reduce the pressure by about 1/4 to 1/3 and can last up to 7 years. Or we could put in a little stent called a hydrus, and that basically scaffolds the piping network and has a little snorkel to the front part of the eye, which drains the fluid through. Those are the most common implant ones. More recently, we have something called mini inject, which is again a little stent that diverts the fluid to drain in a different pathway. And then we've got the non-implant MIGS, and the non-implant MIGS are things like injecting some gel into the piping system. So basically there's that little drainage spongy tissue called the trabecular meshwork, and right behind it there's a circular pipe, if you will. So we can inject some gel all the way around to widen it, and that also gives us about 25% reduction in pressure. That's called viscocannulostomy. There's another treatment called a goniotomy, and this means to basically strip off the top of that drainage system that is fibrosed and no longer working, so that the fluid accesses the piping directly. So that's just a very quick rundown of minimally invasive procedures. There's also external lasers that we use on the outside of the eye that have a good pressure lowering effect, and they're quite different from the SLT. They work more on lowering production of fluid rather than enhancing.
So if I'm hearing you correctly, it sounds like if somebody has cataract issues, it may also be a good time to talk with their ophthalmologist about glaucoma treatments and sort of get that done at the same time. Is that right?
I would rephrase that and say it's an unmissable opportunity to get a little bit more juice of glaucoma treatment for you, because we're already there. We're already entering the eye, and anytime we enter the eye, there's risk associated. So it's not like we want to come back and do it later, because that exposes your eye to risk again. And we want to minimize all the risks and maximize what you're getting out of that one trip to theater. So anybody who has glaucoma should strongly, strongly, strongly consider having a minimally invasive procedure at the time of cataract surgery, but at the same time, while they're aware of how it's going to fit in their glaucoma paradigm. For example, if they're on one drop, having a minimally invasive procedure has a 75% chance of getting off that one drop. If they're on a number of drops, but their pressure is not well controlled, there's a 75% chance of controlling that pressure rather than going on to more serious surgery. And finally, if they can't tolerate a number of drops, but they're taking them anyway because they don't want to go blind, then that's also a possibility that we can reduce the drop burden to sort of just give them better quality of life, better ocular surface, not be bothered by, a speck in the eye all day long type of feeling. So I think I would say it's an unmissable opportunity to discuss it, and what each individual patient expects to get out of it, that's a conversation for them and the ophthalmologist.